Okay, so thanks for taking your time out of your summer evening to come by and get training. I know that summer is always a tricky time of the year. So we're going to talk about interfacility transports. And before I get going, how many people are paramedics? Okay, how many people are advanced EMTs? How many people are straight EMTs? You're very advanced EMT. Good. Okay. So a lot of what we're going to be covering tonight is applicable for all levels of training, but the purpose of this discussion is for paramedics, and we'll get to kind of why we're doing this training in a minute. So if I say something that, some term you don't understand or something that hasn't been explained, feel free to interrupt me. I'm going to force you to be interactive. So this is not just going to be me doing death by PowerPoint for 4 hours, because that's a terrible way to learn. So EMTs can learn as well. One of the things that we're doing is I'm trying to use clinical decision making as a vehicle to teach you the advanced paramedic content for the interfacility transport. So EMTs, you're going to learn a little bit about how to make decisions in the field and kind of some psychology of why we think the things we do and how we get tied up in these thoughts and how to break that cycle. So that's applicable for you even if the advanced paramedic content is not. So topic areas, we're going to talk about how to triage calls for interfacility transports. We're going to discuss the scope of practice, which has been changed as of 2019. And we're going to review using online medical control for interfacility transports specifically. We're going to talk about central line access, blood administration. We're going to go over heparin and nitroglycerin. And then we're going to talk about giving drugs that you may never have seen before. So you walk into a critical access hospital, they've got a drip going that you've never administered, maybe you never even heard of. How do you tackle that and safely deliver care for that patient? Because that is part of the new scope. Yes, John?
Well, that's what I want to clarify. With the new protocols, we're able to...
Yeah, so the scope is pretty open-ended, and we're going to get to that in just a moment. Okay, so this is copied directly from the Montana interfacility protocols. I would highlight for you that there is a difference between the interfacility protocols and the pre-hospital protocols. Those are two separate documents, both of which are available on the Board of Medical Examiners website. So this is copied and pasted directly out of the update from 2019. I believe it was January. And this is a very complicated paragraph, but essentially what it says is things that are beyond the scope of a standard paramedic. This is a list of things that they really think require critical care paramedic. How many critical care medics are here tonight? Okay. So that's great because most of this is aimed at taking the paramedic and up training you to do a lot of interfacility work that previously was the scope of a critical care. The state has taken about 80% of the curriculum that used to be critical care, and they're now making it accessible for non-critical care or traditionally trained paramedics. So the purpose of tonight, mostly above all else, is to get you paramedics comfortable with dealing with about 80% of what a critical care medic would be doing on an interfacility transport, because the scope has now changed. So suddenly you have the ability to transport quite a few more patients with quite a few more drugs than you did prior to the rewrite.
Marcus, can I just jump in real quick?
Yeah.
Well, what's happened in Nessie is that because this is now under the non-critical care medic purview, Nessie cannot bill critical care rates for things that used to be, right? And so that's part of the impetus for this is to get.
Yeah. So, the critical care course is many hours, meets many times, typically has like a certification exam at the end, very complicated, usually 40, 50 hours at least. We're boiling all that down into 4 hours. So if I'm moving quickly tonight, that's why. Yeah. So back to the list. Basically, it says that if the patient is coming from an intensive care unit, you probably shouldn't be transporting them unless you're a critical care medic. If the patient is coming from an inpatient unit, like they were already admitted to the hospital, that's another indication that you may need a CC medic instead of a standard medic. If the patient has multiple medications or infusions, okay, so multiple definition is 2 or more, and we'll get back to that in a minute, but 2 or more infusions may suggest the need for a critical care medic. If the patient has a labile condition or vital signs, And that's, of course, open to interpretation as well. So if any of those things are true, then the state is suggesting that you obtain the services of a critical care medic. Okay, and in our case, that's either going to be from MESI, and we have critical care medics, or it may be from flight team, which tend to have critical care medics for their transports, either air or ground. So that's a list of when you should lean on somebody else. This is a list of when you, as a standardly trained paramedic, should feel comfortable with a new expanded scope. And what this allows is for you to transport medications such as antibiotics, steroids, ACLS drugs, vitamins, non-OB magnesium, and really all that means is lower doses of magnesium, because magnesium for obstetrics, first of all, you're going to have a specialty team for that anyway, and second, they tend to be really large doses. So non-OB magnesium, heparin, and other medications as they've been initiated by the sending facility. Okay, so a bag of thiamine, for example, you'd be fine doing that because it's something that the other hospital has initiated prior to transport. You would just maintain it. And you'll notice it says without titration. I think what they're getting at here is if you start transporting a patient on vancomycin and it's infusing at a rate of 120 mils an hour, you are not going to use your clinical judgment to decide, well, I'll turn up the rate. All right. So you're not adjusting the flow of medication, you're just monitoring for a continuous dose. The exception for the titration that they provide for is heparin and nitroglycerin. And the wording of the state's language is, I think, really unclear, but after I read it about 4 times, what I take it to mean is that you may titrate heparin and nitroglycerin. And that makes sense because heparin does occasionally need to be titrated, and nitroglycerin certainly is probably the most commonly titrated medications of everything we're going to talk about tonight. So I think what the state is saying is it's perfectly acceptable for you to titrate nitroglycerin. But these other medications like an antibiotic or a steroid, they would hope that you wouldn't need to be titrating because that's a higher level of training and experience to be titrating drugs. So, any questions about any of that?
Do we have the right to discontinue?
Absolutely, yeah.
Blood, if there's a reaction, discontinue and then treat for
and we'll talk specifically about blood. I'm going to cover a couple of the common complications of some of the meds that you may see more often than not. And absolutely, if you have adverse effects, then we would encourage you to DC the drip, so with or without contacting med control. And we'll get to kind of how to safely give things again that you may never have seen before. So, we're also, you got your scope expanded so you can infuse blood. That used to be the purview of critical care paramedics. So now straight paramedic is allowed to transfuse blood. Heparin and nitro. Heparin is new for the regular paramedic. That was previously again in the critical care scope. Nitroglycerin in the infusion form in the drip was also critical care, and now it's regular paramedic. And potassium is a new drug for you. All right, so curriculum-specific changes. You can initiate or continue magnesium per our local scope. So if you'll recall, Dr. Kremkov did a training a few months ago specific to magnesium for respiratory distress. So you're probably already familiar with that because we have magnesium on the trucks, and that's within our local protocol. So you're going to be able to continue and initiate magnesium. You can, a curriculum that's, specific to critical care. So this is a list of things that usually would be critical care again. But MAG is local protocol, so you could do that one. If you're maintaining a ventilator, that's again a critical care skill. So if there's a vent involved, as a standard paramedic, you would not want to be transporting that patient. If you have to maintain chest tubes are still one of the things that the state defines as critical care only. So if the patient has a chest tube, we wouldn't want a standardly trained paramedic to be transporting that patient. And inferred from the medic scope statement, again, if they have multiple drips, if they're admitted to a hospital already, especially if they're coming out of an intensive care unit, those would all be reasons to think about transferring to a critical care level of transport as opposed to just standard paramedic. Okay? So that's a list of things that you hopefully are not encountering as a standard paramedic. And again, the magnesium is a little bit weird because although MAG is specifically listed under the critical care side for the state, our local protocol allows it, so I think it would be reasonable to include it.
But again, Marcus, the multiple drips and those are not hard stops, those are, you should consider critical care, right?
Yeah, you know, if you look at the overall statement, going back a couple of slides, labile vitals or labile conditions, that's a judgment, right? So multiple drips is a judgment. My personal belief, heparin and nitroglycerin are very commonly given together for non-STEMI patients or patients with acute coronary syndrome. I wouldn't be concerned about a patient that's on multiple drips just because it's heparin and nitro. Those two go hand in hand. I think what they're getting at is if they're on, you know, different drips for completely different situations, like they've got Levophed infusing because they're in septic shock and they have Zosyn and vancomycin, that's a spooky patient, probably somebody that you want transferred by critical care. So I think which drips you're talking about makes a huge difference. That is a little bit of a gray area, and it's my personal belief that heparin and nitro would be well within the scope of a standard paramedic, given that the rest of the situation is not labile or otherwise unstable. So any questions about any of that stuff? I know that was really wordy and complicated, but the state's document is complex, and as Dave pointed out with that question about, you know, any two drips doesn't necessarily mean no, it just means you need to be thinking about, you know, does this fit in the box or is this too much for me? So speaking of does this fit in the box or is this too much for me, let's talk about things that I would like you to know before you get en route to that critical access hospital or before you head out to pick up the interfacility transport. The first one is the last set of vitals, okay? That's really obvious. We live and die by vital signs. It's the most objective way to assess a patient. So even allowing for differences in providers' preferences or levels of comfort with a particular patient, if a blood pressure is 80/50, that means the same regardless of, you know, local preferences or whatever else, right? So know the last set of vital signs. I would also say that it's really important to know the worst set of vital signs. Let's say somebody goes into VTAC and their pressure with a pulse is 70/30. That's pretty scary, right? So then they convert back to a sinus rhythm and their blood pressure is 120/80. Well, you're looking at them and you're like 120/80, that's great. But wouldn't you like to know that at one point they were terribly unstable with that other arrhythmia? And could they go into it again during your transport? Absolutely. So it's not just how are they doing right now, but what was their worst number or what was their worst situation prior to you initiating transport? Because I think that gives you a second data point for kind of what could happen if they backslide to their condition that drove them to present to the outside hospital in the first place. Okay. You want to know current drips, right? That's obviously relevant. If you hear 3 infusions going on, then you know that this is beyond the scope of a standard paramedic and you need to refer that person for critical care transfer. By the way, I would not count any crystalloid as a drip, all right? So LR or saline, I don't think count, right? Typically in the hospital setting where we're talking about drips, we're talking about a medication, all right? And although you could make the case for crystalloids being a medication, I don't think that's the state's intent. Most people don't count those as therapeutic infusions. Oxygen requirements and method of delivery. All right, so how much oxygen are they on and how are they getting it? There's a big difference between an open face mask and CPAP, for example, right? Okay, so CPAP tells us that this is a much more sick patient. And of course, if it's endotracheal tube, then they're on a vent, and we hopefully are not transporting that patient as a standard paramedic. And then what's the diagnosis, right? Why is the patient going to be transferred to a higher level of care? What is it that the provider says is going on with the patient? Because that gives you some clues about what could potentially happen during the transport. Any questions about things to know before you go? All right. Call triage is really, really important, and at Messi, currently, we're very fortunate to have our assistant managers that are leading the charge in a lot of that stuff. I will tell you that in my experience as a charge nurse in the ER, and some of that role at night, including being a transfer coordinator, I would get calls from these outlying facilities asking for transfers to be arranged, and an entire decision about whether the patient goes to the ICU or the floor might hinge on a single set of vital signs. Like when they came in, they looked really bad, but now they look better. We still put them in the unit because we heard that they looked really bad initially. Or similarly, they'll use one or two little words like dusky, ashen, diaphoretic, and that'll clue you in that there's a little bit more going on than may initially have been presented. So the decisions about whether to send a paramedic versus critical care, or whether they can go ground versus flying, are very subtle decisions. And one of the things that is required to make that decision well is to have a good report from the sending provider, right? So we only know what we're told, unfortunately. So if the sending provider calls and says, I've got this guy, he's bradycardic and he needs a pacemaker, and that's what you've been told, that's all you know, right? And they may not give you a whole bunch of the rest of the information that might lead you to a different conclusion. So we only know what we know, and you got to ask the right questions, including the ones that are listed up there. And you just have to be honest about kind of a certain amount of unknown with these encounters, which is really not unusual for us. It's exactly what you do with 911 calls, right? You get dispatched to something for a 911 call. You're told, I'm going to a shortness of breath, and you show up, and it turns out it's something completely different, right? So just accept in your minds that there's a certain degree of change that may occur when you actually get there and look at that patient, okay? So decisions to make when you get to that facility before you begin the transport. A couple of things to know. Under EMTALA, the sending provider dictates the level of care required, okay? So whether that is a physician, a nurse practitioner, a PA, that is the person that gets to decide, does this person go by ground? Do they go by aircraft? Do they go by EMT, paramedic, or critical care? All right? That's an important distinction, the sending provider. A sending provider may or may not know the local state guidelines or scope. That's a complication, right? If you have somebody who's maybe a locums, they're just in covering for a weekend, and they're from, say, Idaho, they drove over and they're working in Superior, they may not know the Montana state protocol or the guideline that 2 or more infusions constitutes a critical care transport, right? So there may need to be a little bit of education that you have to do as the paramedic arriving on that scene. And I refer to scene, but I'm talking about that outside facility. Because they may not understand your capabilities, and it's important that you have good communication about those capabilities so that you don't get loaded up with a patient that's more than you can handle. All right, so knowing that they don't necessarily have this training, you just need to make sure that you ask the appropriate clarifying questions so that everybody's on the same page, all right? And one of those questions is, does the patient need critical care? I think that's a really good question to ask, because the first thing that communicates is you're concerned about the patient. They look like maybe they're a little more sick than you were told. And second, do they need critical care suggests I am not critical care, or I may not be, right? So that may cue them to kind of say, well, okay, let's talk about what you can do in the back of the ambulance during this transport and whether this is appropriate. The second thing you could ask is, do they need to fly, right? And critical care can happen on both the ground and in the air. That's the mode of transport does not define the level of care for the patient. But when you ask, do they need to fly, that does kind of cue people in that maybe this patient's at a higher level of acuity, all right? Now, I'm not saying that every single time you come in you need to ask these questions, but if you go into a facility and you identify somebody that's on 3 drips and they're intubated, right, you're gonna need to explain, this is too much for me. So these are kind of some ways that you can use those questions to begin a conversation if you feel like you're in over your head at the sending facility. How many of you have ever been on an inter-facility transport where you showed up and you were like, whoa, they're way more sick than I thought? Yeah, we've all been there. And I've been more than once at a facility where the physician's already signed the EMTALA, and then they're like, hey, what level of care are you? Oh, EMT? Okay, great, EMT required, right? And then they send you out the door. Because they would like this patient to be transferred, right? So a lot of nurses and physicians would struggle to answer some basic questions about, you know, what's the difference between even an EMT and a paramedic? So that's where I highlight this about they may not understand the nuances of critical care versus standard paramedic. If they can't even always understand EMT versus paramedic, then this is a big ask of them to really make a subtle decision about Well, now there's 3 drips involved, so it's critical care, right? But as professionals, that's part of our responsibilities to make sure we don't take on more than we can handle. And you want to assure that that transfer sheet is signed and that it reflects ALS and not critical care. There are multiple boxes on those EMTALA transfer sheets, and you just want to make sure that you have a copy of that document that's signed by the sending provider saying that your level of care is appropriate for this patient. Because ultimately, that's a huge factor in whether you're doing the right thing. If you've got a valid order from a clinical provider or a clinician saying, this patient is safe to go by paramedic, that's going to be your single best defense about, I was right to take this patient and initiate transport. Okay, so resources for clinical decision-making during transport. Let's say you start driving down the road and you're 30 minutes away and you got an hour and a half in front of you, and the patient is suddenly looking a lot worse than they were in the facility. All right? One of the things that you could do is to call the sending provider back and ask for guidance. All right? This would be especially useful if you just left not that long ago. They're still probably in the building, they haven't gone off shift, they haven't driven home if they are just on call and coming in as needed. And the major advantage of this is that they know the patient pretty well, right? Because they already assessed them. So you could call them back and you could say, hey, the blood pressure is getting a little bit soft. Do you want me to adjust this cardizem infusion? All right? And they could say yes or no. All right? Has anyone had to do that where they've called and asked a question during or after a transport? Okay, so 3, yeah, that's reasonable. Was it useful to you to get that person back in the loop? Yeah, okay. And the other thing is the sending provider, you could say at the end of the conversation, hey, would you mind updating the receiving facility about this change? Okay. That way they can call and say, hey, we heard back from the ambulance, sounded like the pressure was low, I had them turn the cardizem down. Cool. Another thing you could do is to call online medical control for the receiving facility. I think this makes the most sense when you're most of the way done with the transport or over the halfway mark. Because at this point, the decisions you make are going to weigh most heavily on the people that are receiving the patient. And the sending facility, has probably already out of sight, out of mind, right? They're moved on, they're treating other patients or whatever else they're up to. So you can call online medical control. If you do that, they're going to need a full report. Remember that if a patient is transferred from a critical access hospital to, let's say, the hospitalist, the doctor that takes care of you while you're admitted, a general practitioner, then that hospitalist knows about the patient, or at least knows what they were told. The ER physician is completely out of the loop. They don't even know that there's a patient coming, right? Much less that his name might be Dave McAvoy and he might be coming in with some chest pain. All right, so you have to start when you call on medical control from the very top, just like you would with a scene call, and explain the entire situation. If it's a St. Pat's transfer, one of the options that you can do is to call the transfer line, and that number is available on their website. It's an 800 number, and the transfer coordinator is very good at getting a hold of physicians, and they're also very good at conferencing multiple people into calls. They're ninjas with the phone, all right? And they have all the best contact information. So if you're transferring somebody to the care of a neurosurgeon, your best chance of getting a hold of that neurosurgeon to say, hey, when we started the transport, their GCS was 14 and it's now 4. The best person to get a hold of that neurosurgeon, the receiving physician, is going to be the transfer line coordinator, okay? So that's a good resource. And I was told in the last training that Community has a similar service available. And I would imagine that the easiest way to get a hold of them would be just call the Community ER and ask to be transferred to the transfer line. Am I right about that, Jeff?
Well, there is a direct line to the transfer line.
Okay, good. Yeah, so being aware of those transfer lines, maybe having those in your phone or having them at your fingertips would be useful. Those transfer people are really good at getting a hold of the specialists, all right? The other thing that you can do, of course, is to reach out to your own internal leadership, whether that's Messi's assistant manager or in lieu of them, just a senior medic. Call somebody, get their opinion, get a second opinion about what to do with this patient that may have changed on you, okay? I think probably, especially if you've had a major change, like the GCS went from 14 to 3, I think the most reasonable person to contact is the ER at the receiving facility, right? Because ERs do stabilization and management. And I think that's the easiest person because you don't have to worry about making a prolonged phone call, maybe without cell service, all right? The best person would probably be the receiving physician themselves, and that's going to come through calling the transfer line. Any questions about any of that? Yeah.
Can you talk about, so that we can talk to a pharmacist? If we had a drug question, instead of bothering a doc, can we talk? I mean, I know when we call
Yeah.
full trauma, there's a pharmacist down there.
Yeah, absolutely.
Is there a pharmacist for the ED? If I call the number, what do they charge? Can I talk to the
It
pharmacist?
depends on the hour as to whether they're attached to the emergency department, but there is always a pharmacist on duty. And an interesting trivia point, if they're starting heparin in Polson, the double check will frequently come out of the pharmacist in Missoula. So they may already be aware of your patient, up to and including having done the calculations for the weight-based infusion. So yes, you absolutely can call the hospital and ask to speak to pharmacy. And I think that is an overlooked resource. Has anyone actually done that on a transfer? No, okay, because you just wouldn't think of it. But pharmacy is really good for compatibilities, right? IV compatibilities can be confusing sometimes, and you may only have 1 or 2 holes, all right? And you may need to make a decision about how you're going to plumb things together. Pharmacy is going to be great for that. And the other thing that they can do is double check your rates and infusions and talk to you realistically about complications. How many of you have ever looked up a drug and it'll say like 100 or more complications, but it doesn't define the incidence rate? I looked up a drug the other day, and one of the complications, adverse events, was asystole. I'm like, oh, great, that's really useful. I prefer the drug books where it actually says the incidence rate, so you can look at something and say, wow, there's a 20% incidence of drowsiness associated with this medication. So like, that's probably, something I could see, right? As opposed to like asystole, well, I sure hope that's not 20%, right? So pharmacy is really good at getting down to the distilled version of like, what do I really need to know to run this med? The other great thing about pharmacy is, they're going to help you maybe handle that drip that you haven't seen previously, or help you make some decisions about like, what to do to adjust a medication to fit a patient. You're infusing vancomycin and they suddenly get all flushed and red. You remember something that Marcus told you about turn the rate down, but you can't really remember what. You call pharmacy and they're like, yeah, it's probably red man syndrome. It's not anaphylaxis. Just turn the rate down by half. Great. Okay. So you could do that with online medical control, but pharmacy would be another resource for you. Any other questions about that? Okay. So anchoring. The easiest way to think about this is what you've already observed in 911. How many of you, either yourselves or have watched a partner do this, where you're dispatched to an intoxicated male, let's say, right? So in your head, you're like, okay, I'm gonna go pick up an intoxicated person. And you get there and everything suddenly is filtered through the lens of this guy's just drunk and we just need to take him to the hospital. And maybe you don't do a full head-to-toe assessment. You don't take that jacket off. You don't get that full set of vital signs. You don't run your hands through the hair and look for blood. And you get so fixated on what you were told is going on with this patient that you don't really complete a full assessment, and maybe you miss something that somebody else picked up. Anyone ever been there? I know I have, all right? So anchoring and diagnosis and an assessment is a really simple concept, and it just says that the human mind tends to see what it wants to see. There's another version of this called bending the map, where people that are out hiking in the woods, if they become disoriented, they will look around and identify structures and objects in their surroundings and try to say, yeah, that looks familiar, and I remember that rock, and I think we're going the right direction, even though they're totally not, right? Your brain tends to look for things that corroborate your beliefs, and you tend to remove or filter out data that doesn't support your assumptions, all right? So if your assumption is you're walking down the correct trail, or if your assumption is I'm going to pick up an intoxicated male and he just needs a ride to the hospital, that's all that you will see, because you're approaching this through a narrow focus, as opposed to looking for, what else is going on with this patient. And only when you kind of remove yourself from that focus and look more broadly will you pick up on, hey, why is there a bunch of blood on that step next to the, where the patient was laying? And how is it that he got to the ground in the first place? And then you look up and maybe he fell out of a window, or who knows, right? But if you're not looking for the broader picture, it's really easy to miss that stuff. So that's anchoring. So don't be afraid to reevaluate stability and the diagnosis. This happens all the time to clinicians, right? Like, let's say the guy comes in, he's in VTAC, his pressure's 70/30, we cardiovert him, he looks better. In my head, I'm like, I saved Keith. He's better, he looks good, right? And then you show up and I tell you, yeah, Keith is better. And you walk in there and Keith is pale, diaphoretic, altered, restless. He's not better, right? I mean, maybe he's better than he was before, but I'm still anchored in the idea that Keith is okay, so I haven't done the reassessment. Let me give you another example of this. These rapid response teams or medical teams where we have a large group of critical care people come and immediately try to rescue a patient that's admitted to the hospital. A lot of these rapid response teams get called at shift change. Any idea why that might be? Because the nurse who's been on the night shift has been looking at the same patient, and she went in and did one assessment at 8 o'clock, and every time she's interacted with the patient since then, she was anchored in the idea that this patient is fine, right? Well, through the night, the patient has been gradually changing. But what does she see? She sees her original assessment. So then the day shift nurse comes in and says, whoa, this is not okay. Keith looks terrible, right? And so because of the fresh set of eyes, because the new nurse is not anchored, she comes in and says, no, this is totally not okay. We need to do something different, all right? So you are kind of that fresh set of eyes when you show up at the sending facility. They may tell you, Keith looks better, we cardioverted him, he's doing fine, but you may show up and formulate a completely different impression. Be willing to complete your own assessment, especially noting anything that doesn't match what you were told, all right? So if they said that the patient's heart rate was 90 and you show up and it's 140, that's different, right? Something changed. And then that perks you up to ask, okay, what else is going on that they didn't tell me the pulse rate was 40 points higher than it actually is now? Sepsis gets missed a ton. It's probably one of our biggest misses right now in the medical community of Missoula. And one of the reasons it gets missed is because it has a lot of different symptoms that get written off to something else, right? So like they'll come in with tachycardia and they're like, oh, it must be a heart problem. Well, the heart's beating quickly, but the reason the heart's beating quickly is because they're septic, right? And it's so easy to get anchored in like, well, let's give some medications to treat the tachycardia, and you completely forget about the sepsis. And then if it's a bad plan, if the sending facility has just completely missed the diagnosis, what are your options? Well, you can ask questions, right? You can say, hey, do you think the patient could be septic? Are you worried about this blood pressure? Something like that. Another option is to just keep doing the plan, even if it's not the greatest plan. I went to a critical access hospital one time where they had hung dopamine for a patient with tachycardia and irregular heart rates. They had given 4 different medications to this patient to try to lower their pulse rate. And then finally their blood pressure started dropping. So what vasopressor did they pick? They picked dopamine. Dopamine is not the greatest drug for somebody who already has tachycardia and arrhythmias, right? The incidence of tachycardia and arrhythmias with dopamine is significantly higher than with Levophed. So given the choice between those 2 drugs, I would vastly prefer that the patient had been placed on Levophed. Much less likely to cause more tachycardia and tachyarrhythmias, right? But the other thing I would ask you to do is to look and see, is the bad plan working, right? Because that particular situation, the patient was doing fine. They weren't especially tachycardic. Their blood pressure was okay. They weren't throwing PVCs all over the place. They weren't in VTAC. They weren't in the AFib RVR they'd been in previously. So do I need to shut off the dopamine right in front of them and be like, well, clearly, if you'd been thinking, you would have used Levophed? No, it's fine, right? Just load them up with the dopamine, file that away in the back of your mind as, if we run into this problem, I may think about switching my vasopressor. But do you necessarily need to butt heads with the provider for their decisions right there in front of them? No, it's okay, right? The patient's doing fine. lots of bad plans work out just fine. The flight team, and when I flew briefly, when we would show up, sometimes you'd look at your partner and you'd be like, man, what are they doing, right? But the patient's fine. So you load up and you just make sure to continue to monitor it, but you don't need to necessarily change the whole plan of care right in front of them. So my point with this is even bad plans frequently work. And if the plan is working, if the patient is stable, don't go tipping over the apple cart by coming up with what you think is a better idea, because you don't have context, right? Like, they know a lot more, they have more training, and they also have seen the patient for longer, and they're probably more familiar with them. So what may seem like a mistake to you at the time may later turn out to be a good decision. And if you need to change the plan later, then you can do so in the back of the ambulance with a little bit more privacy, okay? And maybe with the benefit of having contacted med control first. Any questions about any of this concept of anchoring or the ability to kind of show up and call something different than what it was advertised?
Marcus, just like going to RTAC recently, we've had a bunch of hypovolemic patients who have been put on leave with it.
Yes.
From trauma.
Yes, classic mistake.
Yeah, and so, I mean, that's just a mistake. That's just like not right. And so
Yep.
you show up, it's not really an opinion, it's just, what do you do?
Yeah, well, so, within the bounds of professional courtesy, and, flight teams, they don't want to come off as condescending, especially to these people that they want to have a good relationship with in the future. But this is an opportunity where, like, let's say you show up and the patient's on a bunch of Levophed, but they haven't been given any blood products. Maybe one of the questions you ask is, hey, do you have some packed red cells available that I could take with me in case they need them? And really you're making a statement there, hey, this patient needs blood. But you put it in a more mitigated way so that you can give them a chance to be like, yeah, sure, in case you need it, here you go. It's less aggressive. And then as soon as they give me the blood and I initiate transport, I'm going to think real strongly about giving it and turning that Levophed down. So yeah, that's a good example.
Continuing a known bad therapy.
That's bad, right? And so in that case, I think you're very justified in changing the plan, right? If all you're doing is squeezing the patient with Levophed and their hemoglobin is 5, what is the delivery of oxygen to their kidneys, to their liver, to their brain? It's terrible, right? So giving Levophed, that patient, I mean, it's really the equivalent of their end organs not breathing, right? If their hemoglobin's super low, so that needs to be fixed, right? So yeah, ask questions. And if you ask questions in a polite, respectful way, you're gonna improve care. But that's a great example, Dave. We do see patients all the time that come in on vasopressors that needed volume resuscitation, ideally with blood products, and they haven't received it.
Would you ever suggest, because I've actually done this, but I don't know if you get on the phone with the receiving facility and say, hey, would you talk to this doc about what I'm about to do, and then do get out?
Yeah, that's definitely an option. I think that's a little bit higher in the level of hostility. So I would start with, I would start with asking, hey, do you have some blood available? Well, so what I did with that patient that was on dopamine and I really wanted Levophed, I was like, hey, do you happen to have any Levophed around in case we need another vasopressor? And they were like, oh, sure. And they reached over and grabbed it and handed it to me. So now I've got Levophed.
So under these new protocols,
Yeah.
if in the situation that we do know better and we get our rating, we're able to discontinue one and now we can initiate another one. Do we have that authority, right?
Yeah.
Now, I'm not at that level yet, but if you're a Trent or a Bieber or whoever,
So the wording is that you can maintain things that were initiated by the sending facility. Okay. So you can, any drip they've already hung, you can continue. All right. The ability to start a drip fresh depends on the drip. All right. So I believe heparin initiation is allowed, blood initiation is allowed, nitroglycerin initiation is allowed. I don't know that you're allowed to initiate vancomycin, right? So if you get there and you're like, oh, it's totally sepsis, you're not allowed to go hanging antibiotics, but you don't have those antibiotics anyway, right?
Sure.
So most of this, the state's intent, I believe, is to have you continue care after it's already been initiated. So I think their intent was not for you to second guess the clinician in the back of the ambulance immediately after having left the facility. But that gets back to kind of asking those questions. If you show up and the patient's on 15 Alevafed, I think you're very reasonable in saying, number one, do you have any packed cells available? And number two, are you still comfortable with this patient going by ALS as opposed to critical care? Does this patient need to fly? Is there any other source of this hypotension that we haven't addressed yet? Do they need a chest tube? Do they have a tension? Whatever, right? I think those are good questions to ask. And really, the reason I'm focusing on this, instead of just giving you guys a bunch of flashcards about the mechanism of action of heparin, which I could have done, I really want you to approach this holistically and thinking about this is how you make safe patient transfers, right? It's these abilities to assess and reassess, and it's asking those challenging questions and knowing your limits and being willing to say to a clinician, this is beyond my comfort zone. Because the decision to just throw somebody in the back of the ambulance and drive real fast may work if your transport time is 10 minutes. But when it's 2 hours or maybe 4 hours over snow-covered roads, the last chance you have to make a really good decision is before you leave, right? After you've left, all of the decisions you make are much more limited, right? You're not gonna conjure up O-negative packed cells in the back of your ambulance if you didn't already ask to have them sent, right? So I wish there was a more clear-cut way to answer that, but yeah, it just does require a little bit of professional judgment on your part. Yeah.
So if you're going to discontinue something, do you call for that, or should you call or call a pharmacist or the doc?
Yeah, I think it depends. Always if you have time, I would say contact online med control.
Yeah.
If suddenly they're covered with hives and they're having anaphylaxis from the antibiotic that you're infusing, turn it off, right?
Yeah.
You can always pause something and make a phone call. That way you're not continuing to do more harm.
Yeah.
And just like every other thing that we do with online medical control, there's the decisions you need to make right now. Don't wait and make a phone call, just do it. And then there's the things where it's let's, we have a minute. Let's make a phone call and involve somebody with more training and experience on this decision together.
I'm talking about that Levafed hypotensive, right?
Yeah, I don't think ER docs want the phone call, hey, his blood pressure has been dropping for the last 15 minutes and I didn't have any cell coverage, so I haven't started anything yet. No, do it, right? It's in your scope. It's there for a reason, But, and we're going to get to this, if the blood pressure is dropping and you're suddenly on Levafed, as soon as you pop into cell range, make a phone call, right? Don't show up and never have updated the receiving facility until you're on their doorstep. Let them know when they're 20 minutes out, because maybe that's the difference between trauma standby and trauma alert anesthesia, so we can race to the OR, right? So your phone call at 20 or 30 minutes out makes a huge impact on that patient's trajectory of care. So, communicate. All right, so speaking of which, if you have a major change during transport, I would urge you to use the radio to call the receiving ED. Those radio transmissions are recorded. That's useful, right? Because later you can say, look, I let everybody know. Because what do you always hear about, from the ER? They're like, oh, we weren't told. We didn't know. You didn't tell us it was this bad, right? Anyone ever heard that? Yeah. So use a radio report. It's a way for you to document that you were concerned, all right? Use words like, there's been a major change during transport and I am concerned about this patient. That will clue them in. A lot of times, if the patient is already planned to go to the floor, it takes somebody like you saying something like, there's been a major change and I'm worried about this patient, to change the plan. Otherwise, now they're already planning to go up and they're going to 4 South. They've just got a broken hip, that's all, right? So if I don't hear words from the transporting agency, like this is totally not what we were told and this patient is not doing well, then I'm not gonna break that plan. I'm just gonna send them up to the floor and life is good, right? So make sure to communicate that so that we know, hey, things are different and we need to make a new plan. If you're not going to go to the ICU or the emergency department, you need to verbalize your concerns and highlight the changes, all right? And we're going to get to the difference between going to the floor and going to a resuscitation area in a minute. But just recognize that there's a huge difference between going to direct to the floor versus going to a place like the ER, okay? And if you're at St. Pat's and you've been totally not listened to and they're like, yeah, whatever, just go to the floor, Trenton, we don't want to hear about it. One thing you can do when you get there is ask to speak directly to the stat nurse. The stat nurses, which is one of my jobs at the hospital, one of their tasks is to go around and see all the patients immediately after they arrive at the facility. And the reason we have that is because sometimes transfers are not as advertised, or they've changed. So we want somebody with a critical care background to go around and look at that patient and make sure, is this patient still appropriate to be on the floor in the room that they're in, okay? And at community, the alternative to that, lacking a stat nurse, would be just simply ask to speak to the house supervisor. And then again, that would be another opportunity for you to say, hey, just so you know, we were told that their blood pressure was fine, but we've had 3 episodes where they've dropped into the 60s and we've had to give fluid boluses, right? That's a very different patient, right? So there's been a change, and you want to let people know about that so that they can change the plan. All right, so we're going to do a scenario now and force a little bit of participation. You are dispatched to a critical access hospital for a 55-year-old male who presents with dizziness and syncope. The location is 1.5 hours away from Missoula. The blood pressure is 84/50. The pulse rate is 50 and a sinus bradycardia, 94% on 4 liters of oxygen. You've been told that the diagnosis is a symptomatic bradycardia and that the patient probably needs a pacemaker, which is why they're being sent to Missoula. The interventions that the outside hospital provided were 1 liter of saline, and they've initiated 5 mics per kilo per minute of dopamine. The plan is to admit the patient to 4 North at St. Pat's, which is cardiology. All right? What do you guys want to know, or what do you think about this? Is this a patient that you could reasonably be asked to transfer as a standard paramedic on an interfacility? Does it fit in the criteria? Yeah. Okay. This could absolutely happen tomorrow. This exact patient has a standard paramedic transfer. Or for any of you EMTs, you could be driving and be the other half of this patient care team. Anything else about this? Okay. So you're an hour away from the receiving facility, 30 minutes away, you've been underway, and suddenly the blood pressure is 70/30 and the pulse rate is 60. So you have some decisions to make. You're in the back of the ambulance. Are you going to give more fluids? By a show of hands, how many of you would give more fluids to this patient? No one wants to give fluids? Trenton would give a little bit.
Can you go back?
Yeah,
Yeah.
I mean, how much are we infusing here?
So he's had 1 liter of saline, and he's already on a vasopressor.
Was that saline bolus? before
Yeah, that was
or it on a
bolus.
drip?
Yeah, that was bolus. It was
So
all
he's
gone.
not currently on any when that happens.
No.
So yeah, you can try.
Yeah.
You can try some more.
Okay. So maybe a little bit of fluid.
See if he goes up.
Okay.
Has his temp changed? Is he alert and oriented?
He's pretty confused. He's a little out of it. GCS is now 14.
What's his normal?
He was just as normal as you, Bob.
Oh,
Yeah. How many of you would titrate the dopamine? By show of hands. Okay, Bob would increase dopamine. Okay, couple for dopamine. Anybody else for dopamine? Okay, couple. Anything else anybody would do about this? Okay, put some pads on. Okay, so Bob says call the receiving physician. I think that's a really good idea because we've had a big change. Okay, blood pressure is not what it was. All right, what else?
I want to know why stats are 94 and requiring 4 liters, and if he's septic from pneumonia or if he's
Yeah.
CHF and heart failure.
Yeah, is this heart failure? And Trent said sepsis. Okay. All right, so this is a real patient, and I made up kind of what would happen based on your decision making. So if you repeated a temp, you would have noticed that it was now 40. Okay, he's fevering. That's one of the reasons that his pulse rate's a little faster, and he got a little vasodilated, so his pressure dropped. Okay, so his temp was 40, and that would cue you to reread the history and physical that they hopefully printed and sent with you. And you see that the white blood cell count is 18,000, 10 being normal. Okay, so if you had repeated the temp, just that one thing would have clued you in because it got you out of the anchoring, right? You looked beyond just this guy needs a pacemaker and you saw something a little bit bigger. So you call online med control and you discuss sepsis like Trent was thinking about, and Bob talked about online med control. So med control said, yeah, I agree, you should give 30 mils per kilo of LR and you should turn up the dopamine to maintain a MAP of 65, all right? And maybe dopamine's not the best choice for this patient. So maybe after the ER doc suggests it, you switch to Levophed, all right? And upon arrival, the blood pressure is 100/60, and the patient gets changed from going to the floor to going to the emergency department because they had this big change, and because you called the ER doc, and the ER doc said, no way this patient is safe to go to the floor at this point, I want to see him in the ER, okay? So antibiotics, which is the thing you couldn't just conjure up in the back of the ambulance, you're not just synthesize vancomycin, but antibiotics got started promptly in the emergency department because the ER doc was already thinking about sepsis, you already talked to them, and they went to the emergency department. So that's a place where antibiotics get given quickly, all right? So the chance of in-hospital mortality for this patient, remember they're still in septic shock, they're on a vasopressor and they had a delayed start for antibiotics. It's probably somewhere between 30 and 50% mortality for this patient, okay? So not great, but a lot better because of what you did. So if all you did was to titrate some dopamine, you just turned it up and the blood pressure got just okay, so nobody was really too concerned about it and the patient went straight to the floor, then the patient eventually is going to decompensate, right, because they are septic. And 12 hours later, they get transferred to the ICU, and the ICU doctor recognizes the sepsis, but it's 12 hours later, okay? And the in-hospital mortality rate for that patient is probably somewhere between 3 out of 4 and 4 out of 4, okay? And the reason for that, again, delayed recognition, delayed interventions, including the antibiotics, and didn't get adequate fluid resuscitation, okay? So that's a big miss. Now, is that all your fault that it took the hospital 12 hours to catch up?
Of course.
Of course it is, right? They're anchoring too, right? Because they were told this guy needs a pacemaker and he's bradycardic, so they put him on the cardiac floor and they said, cardiology, see him in the morning. So the ER doc, or the cardiologist is going to see him tomorrow, right? Maybe he doesn't even see a doctor for 12 hours, right? These 12 hours. So not entirely the hospital's fault, but you have the ability to make a big impact on this patient's trajectory of care by doing something as simple as checking a temperature, all right? And if all you did was give fluids, then the patient developed decompensated heart failure. So Trenton picked up a little bit on this. He said, why are they on so much oxygen, right? And the heart failure was from sepsis. So sepsis does cause stunning of the myocardium, and it can weaken the ability of the heart to eject blood. So your fluid bolus backs up and goes right into the lungs. The pressure is basically going to be the same. Pulse rate is going to stay the same. Sats are going to get a lot worse after you escalate some oxygen. And is this patient going to do any better in the hospital? No, because all you did was drown them. You just gave them, you know, decompensated heart failure on top of their sepsis, right? So the take-home points for this: complete your own assessment, all right? Don't get anchored in, this guy's got symptomatic bradycardia, that's why he has low blood pressure, and he just needs a pacemaker, just drive, okay? You can be more than that as clinicians or providers. Upon the decompensation, repeat your assessment, all right? Even if you accepted what they told you initially, when the patient changes, start over. And be willing to reconsider the clinical impression. Research shows that up to 50% of the diagnoses that come out of the emergency department turn out to be wrong. And the reason for that is we don't have a long enough window and enough time to test people to really know what's going on. So, you know, just because somebody says this is what's going on with the patient at a critical access hospital with limited resources and a compressed time frame does not mean that that is absolutely what's going on. So be willing to challenge that and rethink for yourselves. Get help when it feels wrong, okay? When that patient changed, when the blood pressure was lower, reach out and talk to somebody. The mortality from sepsis changes during the duration of transport, and you can change the outcome by doing something simple like getting the person diverted to the emergency department where they're going to more promptly see the right people, okay? So here's another scenario. 76-year-old female admitted for 48 hours with COPD exacerbation to an outside hospital, critical access, all right? 2 hours away from Missoula. So you've been called to transport this patient. Vitals are blood pressure of 112/70, pulse rate's 117, respiratories are 40, and she's 91% on BiPAP. The diagnosis is COPD exacerbation, possible pneumonia, and the plan is to go to Missoula for a pulmonary consult. Anything anybody else wants to know about this patient?
They're labs.
Okay, so look up some labs.
What was our lowest stat?
Lowest stat was 880 before we put her on the BiPAP.
What is their baseline set?
Yeah, she's got some COPD, so she's usually 87 to 90, somewhere in there.
Any other significant medical history
Um,
besides COPD?
she's diabetic, but it's well managed. Yeah,
What was my sugar?
110. ABG. ABG is good. She's got a little bit of respiratory acidosis, but it's compensated because she's a lunger. She's always a little bit out of breath. You know.
Has she ever been intubated?
Oh, that's a good question. She was intubated 3 years ago for pneumonia. Okay. Anything else? Those are good questions. Those are reasonable things to ask at the facility, or before you even get there. What's that?
We got a 10.
10. This time it's normal. It's 98. Good, good. All right. Okay, so is this patient okay to transport by standard paramedic?
She's not on any drips at all.
No drips.
We're moving her from BiPAP to CPAP.
Okay, so Trenton points out we're moving from BiPAP to CPAP. Is that okay?
Depends on if respiratory therapy says it's okay. I've had those, most of our now we've had to say, we don't have BiPAP capability, can we put this patient on CPAP?
Yeah.
They've managed to do that.
Definitely a decision that I would want the clinician to be involved in as well. Yeah. So maybe. Technically, EMTALA says that there cannot be a lower level of care. And at another place that I worked, far away from here, we had a terrible incident where a patient died during an interfacility transport. And one of the things that got pointed out was we didn't have a respiratory therapist in the ambulance. We had a paramedic who was trained with ventilators, but not an RT. So they argued in the legal case that followed. They said there wasn't the same level of training in the back of that ambulance as there was in the facility. I think that's a little bit reductive because, you know, we also don't have doctors in the back of the ambulance, right? But the second thing that the lawyer was able to point out was that the ventilator the patient had been in the intensive care unit at the first hospital was a pressure rate volume control ventilator. It was a very specialized ventilator that prevented the patient from sustaining barotrauma or too much pressure in the lungs. So we took the patient off the PRVC ventilator, the very high-speed hospital ventilator, and we put him on a very simple little rate volume ventilator without those safety pop-off parameters. Well, that caused the patient to develop a pneumo, and that progressed to a tension, and the patient died. So the argument from the lawyer was EMTALA requires continuous level of care, and that's both training for individuals and also equipment, right? So again, that's kind of ridiculous. We're not going to have as great a ventilator as they have in the hospital. But their argument was this patient wouldn't have had this bad outcome if you'd had a better functioning ventilator, okay? So the decision to go from CPAP to BiPAP to CPAP technically is a violation of EMTALA because you're reducing the level of care. Now, if the clinician says on their sending document, I feel that this is acceptable and reasonable, sure. But do you want to take that patient and find out if they're going to tolerate CPAP in the back of your ambulance? I don't, okay? So are we maintaining the level of care? I would argue not, okay? So that would make me a little bit concerned. Okay, so if you asked questions during the transport, it got rescheduled and flight took the patient and everything was fine, all right? If you transported, then the patient decompensates during transport because you flipped from BiPAP to CPAP. And you attempted intubation, but you failed because they had a clenched jaw. And of course, we don't have any paralytics. So you bag valve mask the patient by yourself in the back of the ambulance for the next hour with increasing difficulty with ventilating and abdominal distension, right? Because you're pushing all that air in the gut. It's harder and harder to ventilate. Did that transport exceed your scope? Yeah, probably. Okay. What if they check the box for ALS and the doctor says, yeah, you're good to go, CPAP's fine? Does it exceed your scope? The state would probably argue that those were labile vital signs or a concerning patient that you probably shouldn't have transported. 91% on BiPAP is like not doing very well with maximum support short of the intubation. What do some of you with different backgrounds think flight would have done with this patient? Anybody think flight would have had that patient intubated before they left the facility? That happens all the time, right? And why would flight do something like that?
So they can control the airway.
Yeah, so they can control the airway, because nobody wants to crash intubate in the air, all right? And anyone that's ever flown for any length of time knows that that's a really bad day at the office, all right? So a lot of patients that look like that would get intubated for flight. Knowing that, how do you feel about having a longer transport on the ground without the luxury of even escalating to paralytics because they're unavailable to you by protocol? So if the flight team has a shorter transport and access to paralytics and they don't want to do it, does that make you want to do it on the ground? No, right? So this is kind of getting back to that, like knowing your limits and asking the right questions, all right? Now, I'm not saying you can't take a patient on CPAP and transport them. It happens all the time and they do just fine, all right? But I would submit to you that out of all the patients that you could call me to do a transport tonight, the one that I would be the least comfortable with is the patient that's already on positive pressure ventilation. I'd rather have any other patient because I don't have paralytics. And because for me to intubate that patient without paralytics, they're gonna have to be at death's doorstep, right? So I think somebody that's on continuous positive pressure ventilations and unable to tolerate cessation of those positive pressure ventilations, the CPAP, BiPAP, is a really spooky patient, and you should think twice and 3 times about whether you should take that on the ground, okay? I'd rather deal with a septic patient on a little bit of Levophed all day long instead of dealing with that patient. Because sepsis, you know, if they've gotten their antibiotics, I can always give more fluid, I can always turn up the Levophed. I can't always do any more for somebody that's already on BiPAP and not doing well. So just something to think about. All right, so let's talk a little bit about doctors. ER doctor is a resuscitationist. Now, resuscitationist is kind of this term that you see kicked around on some of the boards. You see it on MCRIT a lot. And really what they're talking about is somebody who goes in and takes a sick person and stabilizes them. Scott Weingart on MCRIT says that resuscitationists include paramedics, right? It's what we do. We show up, somebody's sick, we make them better. So ER docs are really good at reaching in there and saving lives, making big changes. They exist in a critical care area. They have critical care nurses. You go into a trauma bay, there's all the toys that you need immediately available. There's a pharmacist. And this is a place where there's a large ratio of highly trained people to patients, right? So we can afford to deliver a lot of attention. What happens when you bring somebody in that's critically ill and you put them in a trauma bay or a big resuscitation area? There's like 15 people around them and things happen, right? It happens quickly. So that's an ER. ICU is going to be staffed by a resuscitationist in all probability. And I say that probability because sometimes the ICU doc may or may not be physically in the ICU, but they're going to be close by. It is also a critical care area. They have a lot of toys, and the timeline for the interventions is going to be now to soon, right? Even if the ICU doc isn't physically in the building, they can get there within a few minutes because this is an area that takes care of really sick people on a regular basis. A hospitalist is a general practitioner. They may be in a critical care area, like hospitalists can admit patients to the ICU, but it may be in a non-critical care area, like on a floor or a step-down unit. And they may not see the patient right away. There may be 1 or 2 hospitalists for every single patient admitted to the hospital, and there might be 150 people on their service that night. So they might not come around and see your particular patient right away, all right? You go into the ER with a really sick patient, hopefully you see that ER doc like before you leave, right? But if you take a patient to the floor, they may not see that hospitalist for an hour or more because they may be admitting 2 other people in the emergency department, and then maybe they have to go to deal with some other situation. Then they'll come see the admin, all right? So just recognize that there may be a delay before that clinician actually goes and sees the patient. A specialist has a narrow field of expertise. They're really smart people, but they only know about bones. One time I handed an EKG to an orthopedics doctor. He had brought his wife in because she was having some chest pain, and out of some professional courtesy, I was like, oh, maybe he's interested in the EKG, so I handed it to him. He started laughing and he said, I wouldn't know what any of that means. All I do is bang on bones. And he was being humble, but what he was really saying is, I'm out of my league here, right? So he's obviously a very smart guy and he does good work, but he does it on bones, all right? So they may be critical care specialists or they may not be. And they may not see the patient for up to 24 hours. That's a big trivia point. The hospital bylaws for both of these hospitals in Missoula say that if a patient is admitted, they must be physically evaluated by the admitting physician within 24 hours. So really 23 hours and 59 minutes. That's amazing. That means that if you get transferred from, I'm just picking an example, Ronan, and you come to St. Pat's with a non-STEMI, you may be in that bed for 14, 16 hours before you see a cardiologist or a nephrologist or an orthopedist or whatever the situation is, especially if it's overnight. So why am I telling you this? I'm telling you this because you may be one of the last people to kind of look at this patient for 12, 14, 16 hours, right? And the next person to look at this patient might be a specialist who could really suffer from some anchoring, right? Let's say you're treating a 90-year-old female who has a humeral head fracture because she fell and she broke her arm, right? So she's going to be transferred to what? Orthopedics, right? And what is orthopedics going to do? They're really good at putting those bones back together and getting that humeral head back attached to the rest of the humerus. Is the orthopedist likely to pick up on maybe the reason she fell is she's been really weak the last few days and she's got brewing sepsis? No, they probably don't ask those questions. That would be more likely to be asked by a hospitalist, even more likely to be asked by an ER doctor, right? But think about it, paramedics ask those questions too. Why did you fall, right? But if an orthopedist gets a patient transferred to them because of a broken humerus, they may not be as likely to be thinking about all the other things that led up to that patient being transferred to their care. And they may not see that patient for 12 or more hours, which means thinking about sepsis is a little late, even if they do get it right, and it's 12 hours later. So any doc can anchor, but it's especially true in the specialty areas, right? We're all just human. Nature is to anchor, like we already talked about, but it's especially going to happen when you're fixated on a narrow set of problems. The reason I'm talking to you about this is because I want you to think more aggressively about how you're communicating about those patients, because that really does make a big difference. And I'm hoping that with these scenarios I'm illustrating to you that the decisions you make, the assessments you make, have a big impact on total outcome. All right, so finally, communicate. Online medical control helps you fix it now, and it reduces the time to definitive care. If you don't call, like Dave's scenario where the patient's on too much Levophed, really any Levophed is too much in a hypotensive trauma patient, right? Because what is all hypotension and trauma until proven otherwise? Hypovolemia, it's all bleeding. Until you prove that they're not bleeding, it's presumed to be bleeding. So should you ever have Levophed on a trauma patient? I mean, maybe, right? But you better be darn able to prove that they're not bleeding somewhere. So if you communicate early, you'll get a better result for your patient, up to and including changing where that patient is going to go. Because if that patient's really sick and they had a big change in transfer, or maybe the sending facility just plain screwed up and didn't tell us a good story, would you like them to go to the floor where they're going to see a specialist in 16 hours, or would you rather have them see an ER doc right now? I'd rather have the ER doc right now. Where they go, the ICU versus the floor, and the type of doc they see is going to directly impact their overall level of care and when they get it. Okay? And whether they see the doc on arrival in an hour or in 24 hours, and that all depends on how you communicate about what's going on with the patient. The reality of modern medicine is there's a lot of patients and we're spread thin and we have to make do with what we've got. And a lot of these patients, the reality is they can afford to sit there for 12, 16 hours and they do just fine, all right? But some of these patients can't wait. And in some of these scenarios we talked about, they do need adjustments. And your assessments and the things you communicate make a big difference in how timely that care is provided.